Morning. Am I audible?
Yeah, you are. Sanjay, go ahead.
Wonderful. So we are in Operation Theatre 3. Welcome to the morning session. We just saw a wonderful demonstration by Dr. Navita, our physiatrist, who is handholding the program of ICBPS pain therapy overall. Other than the oral therapies, everything is being taken care of her. For the Department of Urology, which includes Dr. Bijoy Abraham, he could not stay back today because of an emergency that he had to go. Dr. Ismail Attar, my colleague out here, and myself, our colleagues and students out here in the whole department. So the demonstration of the next case is regarding a cystoscopy. And I'm glad the entire audience is there. The cystoscopy in interstitial cystitis bladder pain syndrome with the kind of significant symptoms that she had as a vaccine waning phenomena. Just a few minutes of history on this. Keeping all anonymity intact, she is 50 plus. She has had these symptoms for last 4.5 years. Has undergone 2 cystoscopies during her clinical period of therapy, where first one was cystoscopy and hydrodistension. She had adequate bladder capacity. If the records speak right, she had global Hunner's lesions on all aspects. We did not have a consent for fulguration or resection at that point in time. Her clinical history was of a very aggressively progressing issue over the 4 to 5 months after an initial aspect. Looked like a flare. So when the cystoscopy happened in such a exaggerated situation, we looked at global Hunner's lesion on the anterolateral posterior walls around, and we put her on oral therapy, a combination therapy to take care of her pain, pressure, discomfort, to take care of her urinary symptoms, and the overall symptoms that she was going through with the combination therapy, which on day 1 has been discussed at length. She recovered well, and therefore I say she had a vaccine waning kind of phenomena. The medicines came down on the pain therapy. She was on oral pentose and polysulfate. 9 months later, she subjected herself to an evaluation because there was possibly a flare, which was because of a documented UTI. She recovered from that. That recovery did not bring her back to her original state, which she had actually recovered from. So as expected, customary that there were Hunner's lesions this time, the family agreed that we could take a cystoscopy and proceed with aspects as required. This is 9 to 11 months after the first cystoscopy.
So this first one where they diagnosed the global lesions, that was not with you, somebody else's?
No, with me. With
me.
Okay, with me.
Okay, right,
with me.
Right.
So after that, her symptoms recovered on a very concerted, escalating therapy on a medical management, on a very close follow-up monthly for the first 3 to 4 months. She came to a baseline where she said, I feel good, I'm comfortable, and as expected, she would disappear from her follow-ups for a while, which gives you an idea that the patient is doing well. Some telephonic conversations, that's it. In the pandemic, that she had a flare, which was an acute UTI, which was treated. This flare recovered, she came to a baseline, but never what she was in the first 9 to 11 months, which made us understand that we need to anyway go to cystoscopy to look at the lesions around. We went in, and to our surprise, the lesions had disappeared. There were new lesions, which we look at what. So the new lesions were again concerted around. We got her back on the full therapy. She recovered, but she never recovered to a level what she is. Her complaints at present, when I took a history last week when she came in around, is a discomfort in the region of the pelvis when the bladder fills up. The discomfort is too much. She holds her hand, goes to the washroom, and passes urine. She has this, Sanjay, she has this very important aspect, what I call as painful urgency. The urgency is preceded by pain, and pain is so much. She voids good amounts, he says, at times, but most of the times it's painful urgency. Still passes anything between 8 to 14 times in the day, and 1 to 2 times at night. Gets up with pain when she gets up. I just went out and asked her in the morning before we took her in. She said, I got up twice. Both the times were very painful. So with that history, I'll just go in and have a scopy. And the scopy, which is live right now, will give us an idea. Do you have any questions before I scope her?
No, I think you can start off. Let's. Is she under a general anesthetic? Or?
Yes, always under general anesthesia. So she wasn't apprehensive. She knew she's a part of this team of global clinicians who have actually come in around to assist her to get treated. So just to tell you that all the 3 patients we are doing cystoscopy have agreed to kind of a deliberation and a consensus that we possibly create. Therefore, there may not be much therapy which I may show on table, but it's a consensus that we are arriving as global clinicians at the Kokilaben Hospital GIBS program, where we look at, is there a way out for these patients around? So that's what was discussed yesterday. So let's move on and have a look at it. Do you have an endoscopic view right now?
Go ahead.
I have a comment.
Yeah.
Let me know if you have an endoscopic.
We have an endoscopic view.
Perfect. So we go in. Let's have a look.
Actually, what Sanjay said, that I also see patients, and when you do a recystoscopy, the Hunner's lesion heal, or Hunner's lesion may appear at other place, but there are patients where Hunner's lesions are there initially, and then they heal, but the severity of symptoms remains same.
This is your first pass, right? You've not gone in.
Just the first pass.
Okay.
I have actually
Good.
closed my water
Okay. Sure.
only to look at if she has any urine left over. She must have passed minutes before she came in.
Right.
And I'm not filling up too much. I'm using the urine as my medium till I start filling up.
And this is a 30-degree scope, right?
Yes. So that is an area which was, if I can show you that.
That looks like a scar.
So that's a scar of a healing. This was angry looking approximately 17, 19 months ago in the pandemic. Can you see the other one here?
Yeah.
So it's, as I said, anterolateral wall, lateral wall. I'm not yet ballooned the bladder. I'm not looking at the capacity. I'm just looking at what is in store for us, and then we'll have a look at it.
So since you have a large experience, Sanjay, I'm going to ask you, how would you differentiate between the scar of the procedure that you did the last time round and something that is there as a de novo problem that you're seeing now?
So a new lesion will show as a central slough with those angry-looking radiating vessels radiating all across, compared to the notes that we have on patients and the history about patients who have fulgurated. So fulguration is very low electrical current. We use fulguration more. As a team, Dr. Ismail, Dr. Bijoy, and myself we don't use laser. We have resected a significant number of patients also. In those patients who look like resectable, we don't use triamcinolone injections here.
You have some comment on what you are seeing there?
So I'm just showing you because I've not yet used water yet. I'm just trying to show you that if you ask me about this was angry-looking lesion in my close memory and the recordings that we have approximately that many months ago.
There's almost like a bullous vesicle there, right?
Yes, so this one has always stayed.
Oh, it's been there before.
This has always stayed around from the first cystoscopy. I will now move on to the anterior wall and I'll start filling because the picture changes dramatically in many patients who even don't have a lesion. Let me start filling up the bladder now. So as I fill the bladder,
right,
we will have a look at and
so while the bladder is filling, do you have a difference in approach to how you take care of the Hunner lesion once you see it based on whether you find one or two or you find, as you said, a global set of Hunner lesions? Do you inject them or do you fulgurate them or what do you do, or resect them?
Wonderful question. So first of all, like you have a cystoscopy for tumors that you map, we map the bladder as to where the lesions are. And once the mapping is done, we know what we will do. Many a times, we will very partially fill because if you're doing a procedure, everything will be lost because if there's bleed and if there is also glomerulation, so the whole thing will change. So yes, we then make a plan on the table. The patient therefore has given a consent on occasions as to you could go ahead with fulguration, etc. So the Hunner's lesions are not usually an expected lesion. Otherwise, Dr. Nagendra and Dr. Taneja would tell that this patient doesn't necessarily has a Hunner's lesion, which not. But yes, the clinical history of gross aggravation is something which I have looked into. Many of the patients suspicious about a possible, because there was an era when if cystoscopy is normal, even we would look at there's nothing, but that's not true. So non-Hunners and Hunners could become a totally different kind of an aspect.
How much have you filled in so far?
So we may have filled up approximately 250.
250.
Approximately 250. So Sanjay, just to tell you that this bladder looks very different from what bladder we had on day one, first time.
Right.
Yeah, and the bladder looks also different from what it was. So she's symptomatic quite significant. As I said, she holds the pelvis or lower abdomen and walks to the washroom like she did yesterday. And so there we are. So as I move up, you can see the scars of healing by an oral therapy. She has already been an oral, no fulguration for her yet. So you can see that I have gone to approximately 300 kind of filling. Just that I wanted to show you the scars of the Hunners compared to the proper Hunners, which could be visible here. She is looking very different. So you can make out from this a central scar and the aspect. Let me now just travel on the anterior wall of the bladder, just because I know the patient. Can you look at the anterior wall? Is the anterior wall visible to you?
Hello, Sanjay.
Yes.
Shivam here. Yeah.
Hi.
Sure. Good morning.
Dr. Shivam, can you see the anterior wall of the bladder?
Right.
Yeah. Can you see some changes happening around?
Right. So what you said about the scarred kind of ulcers. So usually, even in a primary, when you just go and do a cystoscopy, these lesions would appear like this. And when you do the hydrodistension, then only there is a breach in the mucosa.
Getting it.
And then, so it may be that they haven't healed.
Possibly.
On hydrodistension, you will find that they would breach.
So I will tell you that possibly they have healed compared to what they were. That's only the
Okay.
reason, because both symptomatically. I just want to show you this, Dr. Shivam.
Right.
This part, have a look at the bladder and this part. We
Right.
have distended her to approximately 300 ml of fluid. Have a look at what kind of picture it's visible to you here.
Acha, can you see those vessels? Can you, do they actually?
Can you see the tear? Can you see the tear on the anterior bladder wall?
Right, yeah.
Can you see the mucosal breach happening around?
Yes, that's
We have
what.
stopped filling. We are not filling anymore.
Right.
And just want to show you that part, which is another kind of an aspect discussed in European circles as to what defines a Hunner lesion. Have a look at that anterior bladder wall, which I'm attempting to show you.
Right.
So if those minutes of show, this is the bladder. You can see the breach happening there.
Yeah.
So those breaches actually are happening on the anterior bladder wall,
Yeah.
where we had Hunners in the past, or we probably had, I would not really remember. You can see the anterior bladder wall. We're not filling anymore. We just filled something, and we showed you what does it mean.
So Sanjay, one of the issues has been in trying, arriving at a consensus at what really is a lesion. So if you take any chronically underfilled bladder and distend it, you could conceivably see some of those cracks which you are seeing right now in the bladder.
True.
We know that with even patients with BPH and so on.
Agreed.
So can you for the residents especially, can you describe how you would differentiate a Hunner lesion from just the cracks that you get on over distending and underfilled
So the cracks that you see, Sanjay, a wonderful question for the resident. The cracks that you see right now are related to distension. She cannot distend it. So as you rightly said, chronically unused bladder, because the bladder cannot fill up so much. Now how do you see the cracks out here? Could be a continuum of change that could be happening in the bladder. And now these, some authorities have defined as something, but they may not be. They are also a change in the bladder mucosa or the bladder. Compared to the Hunners, which come as a central lesion, a Hunner's lesion rather than ulcer, which come as a central lesion and radiating vessels around, which I hope to see in the next case, because the symptoms are a little gross. We hope and look into that case around. So just to show you again, because this is the first distension happening around, we have just started distending a shade lesser. You can see now, if you look at the entire global map of this patient right now on cystoscopy today on a Sunday, taking a history of last 4.5 years with exacerbation, I'm just attempting to look at what she was in my first cystoscopy in the just entry, as Dr. Shivam said. The very entry would show the lesions, and obviously if you overfill and stretch, or if you're doing a hydrodistension parallel.
Sanjay,
Yeah.
you're doing well. So I want you to demonstrate that when you decompress, it is only the Hunner's lesion that bleeds. Rest of the bladder is not bleeding. If you look at the area which started bleeding, which is around at 2 o'clock, now this is where the Hunner's lesion was, perhaps. And this is the site that was bleeding. So rest of the mucosa you've distended would not bleed, except for those mucosal cracks that may bleed, that is at the anterolateral area. But if you need to see, the rest of the bladder would not bleed except the Hunner's area, which has been split open. It was a scar that has opened up because the Hunner's lesion perhaps responded to the medical management.
Got it. So Dr. Taneja, we will start decompressing the bladder as we coming to the first aspect around. Let's have a look for ourselves. I mean, we know that this was one Hunner's, which you can see that's classical, Sanjay, of a Hunner's which has partially healed or healed.
Can I ask one question, Sanjay sir?
Make it quick. Go ahead.
So, you said that these are, when you first went in with cystoscopy a while ago, you saw a lot of Hunner's lesions all around, and it was global, but you didn't have consent. So, and then you give medical management and the Hunner's lesions healed. So do you need to fulgurate then if the medical management is helping?
No, so if they healed, I would not fulgurate. I'm looking at active lesions where one of the active interventional therapies is to look at how do we fulgurate and give them a cure. So those active lesions, multiple of them, I mean, we need a consent when we go inside. Many times the consent happens on the table itself. We go and talk to relatives, they have agreed to. But yes, the active intervention on the operating table obviously is with an eye to the future around. Out here, this is one such case where we didn't have a consent. We agreed to, as a first time, give her a medical management, take it forward to the next level. So active management is there in cases of angry looking Hunners, but if you have got global multiple ulcers, you may land up actually, you know, trying to fulgurate and resect almost the entire mobile part of the bladder other than the trigone. So that will be against it. So not having given a medical management, as Dr. Naginder said yesterday, getting into any active management would have been a little bit of a challenge. So Dr. Neja, that was one lesion which actually had healed to some level around. We have activated it by our own technique out here. So this possibly has amounted to a hydrodistension of 300 ml of plus of fluid beyond the urine which was in the bladder when she comfortably came into the theater for general anesthesia. So as we move ahead with looking at what we've understood, that taking this history into picture, an active lesion in the bladder becomes a challenge for the operating team anywhere to be able to decide everything on the table. Many a times, these are the kind of patients where we probably would wait for Gibbs again in other centers too, to look at what could we do for such patients, more than looking at an active decision of anything intravesical, for anything injectable, anything fulguration. So the idea was not today to show fulguration out here. It was more to take a consensus and understand that a cystoscopic picture which is missed out many a time in active patients around. Do you have any questions around? We will terminate this case and continue talking as we move on to the next theater. So chairpersons and colleagues, if you have any question, because you would see nothing in such a patient who has got active symptoms, and you have seen some maybe silent lesions, silent to the initial cystoscopy, but has then presented itself to a complete phenomena of redness. So at this point in time, if Dr. Sanjay asked what would you do, so what we would do is we would have done a mapping in advance to look at the active lesions. They were not as gross and red and as active as I've seen them on the first session. If that would have been there, we would have mapped 3 or 2 or 5 and then would have made a decision as to which all will fulgurate or even resect. Imagine you have only 2 lesions in the mobile part of the bladder, posterolateral, anterolateral. You could possibly very fine resect with a finer, thinner loop and be out with it.
Sanjay,
go ahead.
See, I just want the audience to appreciate that in these cystoscopies, sometimes, though we have done more than 1,000 cystoscopies, day out, day night, we do cystoscopies. But in some of the cases, we are also having some doubts whether we should fulgurate or we should coagulate or we should resect. So it is very important that the cystoscopy in interstitial cystitis patients is done by the senior most person. Even if it is done by the junior, the senior most person has to stand. So like I said in my unit, radical cystectomy can be done by my assistant. But I am suspecting interstitial cystitis. It is me who has to do the cystoscopy. Because these are not easy cystoscopies. That you do cystoscopy and there is a lesion and you find it and you fulgurate it.
Getting it. So,
thank you very much.
Just the last sentence.
Sanjay, just one point.
Yeah.
So this, we have to be careful. We have to be careful about 2 things. We don't hydrodilate, we hydrodistant. And the way to do it is to have the irrigant at 60 centimeters, 80 centimeters from the pubic symphysis.
So I just show you that that's the level we keep around.
Yeah.
So it's an approximate measured.
80 centimeters is decided because that is the mean blood pressure. If you go beyond that, you will cause more ischemia to the bladder mucosa and perhaps cause necrosis.
Just
so
to inform.
all the complications that happen because we don't stick to small things, and this is one. The second is when you are doing a cystoscopy, you can use a drip chamber. So what we do is a drip chamber like the IV set. And you set it at 80 centimeters and you wait for the drip chamber to show you that no more irrigant is going in. And that is the level of hydrodistension. Anything beyond that is hydrodilatation. And all the complications that you read in the literature about hydrodistension and fulguration may be related to the pressure at which you are doing the cystoscopy. Thank you, Sanjay.
So the bladder capacity today at cystoscopy right now is close to 600 ml. That means under anesthesia we could fill to approximately 600 ml is that they would measure exactly, but that is what it was.
So Sanjay, how does that measure up with her bladder diary?
So bladder diary is around 9 to 15 times in this point in time in the month of July and August in the daytime, on 1 to 2 times at night. She is anyway on restricted water intake, but still she goes that much. Her bladder diary, her functional bladder capacity, the highest is around 220 to 240. That's what she can hold. So the lesions may not look active on cystoscopy, but she is into quite a distress and discomfort at this point in time. So discomfort with a good bladder capacity, probably 600 ml on cystoscopy under anesthesia. With her functional bladder capacity of 220, passing urine 8 to 15 times during awake hours and probably once or twice getting up at night with discomfort. Each of them is to hold her lower abdomen and reach the washroom and then empty and then spend few minutes to get a comfort out of it and then come out. Amounts to a patient with very active symptoms at this point in time. So I said it's a very waxing waning phenomena over the last 4 years, of which 2 years have been pandemic plus. We just close. Is there anything else? We just close and move to the other theater?
Yeah, of course.
Only for the paucity of time?
Sure, sure.
Yeah?
Sure.
Okay?
Yeah.
But I can keep talking to you as I move on.
Yeah, yeah. So there's a quick question from the audience. Is she on pentosan polysulfate?
Okay, so I'll answer that once I reach the other side.